Hi, this is Hadas Benhabib, and I'm pleased to present our paper on MRI Radiomics analysis in the Diagnostic Differentiation of Malignant Soft Tissue Myxoid Sarcomas from Benign Soft Tissue Musculoskeletal Myxomas. None of the authors have any conflicts of interest to declare. Myxoid soft tissue tumors comprise a heterogeneous group of mesenchymal neoplasms, which are predominantly found in the soft tissues of the extremities and superficial regions of the body. These neoplasms, including those with benign, locally aggressive, and malignant potential, are all characterized by the presence of substantial extracellular mucoid stroma. It is this stromal component that results in an elevated water content, leading to a distinctively high signal intensity on T2-weighted imaging. Though conventional imaging techniques play a pivotal role in the initial evaluation of soft tissue masses, it often lacks the specificity required to definitively differentiate between benign myxomas and malignant myxoid sarcomas. While distinct entities, these myxoid tumors also share overlapping clinical and histopathological characteristics that complicate their differential and subsequent therapeutic approaches. Most benign mucoid tumors are intramuscular myxomas. They are typically well-defined and tend to be more homogeneous in signal intensity. Classically, edema is seen superior and inferior to the lesion, leading to a bright cap sign, and a thin rim of pericapsular fat can also be seen. Enhancement can be variable, with both peripheral and patchy internal enhancement possible. Malignant myxoid sarcomas tend to be larger and have more heterogeneous signal intensity, potentially due to more complex components, such as intratumoral hemorrhage or necrosis. However, as we can see from this example, overlapping features such as the bright cap sign and peritumoral fat rind can also be seen in malignant lesions. As such, differentiation between benign and malignant tumors can be difficult, necessitating routine biopsies of myxoid lesions. Here is a recent case in our practice of a 30-year-old male with a painless lump in his elbow. On MR imaging, the lesion demonstrated all the characteristic signs of a benign myxoma. It was well-defined, had peritumoral edema and fat rind, as well as minimal patchy internal enhancement. However, on biopsy, this was found to be a myxoid liposarcoma. So this leads us to the purpose of this study, which was to evaluate the diagnostic performance of multiparametric MRI radiomic-based models, as well as models based on qualitative semantic features, in the differentiation of benign myxomas from malignant myxoid sarcomas.
Hi, this is Daniel, and I'm pleased to present our methodology to you. Institutional Research Ethics Board approval was obtained with waiver of informed consent for this retrospective study. Out of a cohort of 849 cases, derived from a database managed through the University of Toronto Musculoskeletal Oncology Unit from April 2002 to June 2021, a total of 523 eligible patients were identified with histopathologically confirmed diagnosis and available pre-treatment MRI. This included 201 myxomas and 322 myxoid sarcomas, with 2 cases excluded because of significant imaging artifacts. Tumors were manually segmented with lesion tissue delineated on every axial slice of all available fluid-sensitive, that is STIR or T2 FATSAT, T1-weighted and T1-weighted post-contrast acquisitions, totaling in more than 1,600 individual segmentations. For intraclass correlation, a randomly selected subgroup of 60 cases, 30 myxomas, 30 myxoid sarcomas, were independently segmented by 3 readers. At the time of tumor segmentations, readers assessed a series of semantic features for each tumor on MRI, including tumor location, neurovascular or osseous involvement, perilesional fat and edema, and transcompartmental extension. Image pre-processing and radiomics feature extraction were performed using MRI Radiomics. According to IPSI recommendations, segmented image voxel signal intensities were normalized and resampled to an isotropic voxel size. Radiomics features were excluded from consideration for modeling if they had an ICC of less than 0.7 and a variance of less than 0.01. For radiomics features, the probability of the tumor being a myxoma was represented in the radiomics score, which was determined using a random forest model employing features determined by the Boruta feature selection algorithm. The ability of semantic tumor features to differentiate myxoma versus myxoid sarcoma was investigated with a univariable regression model with odds ratio greater than 1, denoting increased probability of myxoma. All semantic features with a p-value of less than 0.05 were retained for further analysis in 2 multivariable logistic regression models. Due to incomplete data for certain imaging sequences, 6 different models were developed. The first 2 models included all patients with complete T1 weighted and fluid sensitive data, and the remaining 4 focused on the subset of patients with complete data for all 3 sequences. In the subset, a separate model was developed for each imaging sequence, along with a multi-parametric model that combined the 3 sequences. To derive the models, the respective datasets were randomly split into training and test subsets using a 70-30 ratio. Model performance was assessed using AUCs of ROC curves. The Long's test was used to assess differences in AUCs between different models.
Radiomic features derived from each imaging sequence or model that optimized class prediction were identified. Those features retained for fitted models are demonstrated here in this figure, plotted with their respective predictive impact on model accuracy. GLDM features, which are a subset of second-order features reflective of image texture, were determined to have the greatest influence in optimizing class prediction. The performance of each model was estimated using ROC-AUC curves. For now, I'll draw your attention to the blue lines, which represent our radiomics models. Our analysis revealed that T1 weighted, fluid sensitive, and T1 weighted post-contrast sequences all demonstrated excellent discrimination of benign and malignant myxoid tumors, with AUCs greater than 0.9. We also combined data from all 3 sequences into one model, which also showed excellent AUC greater than 0.9. But comparing it to each individual sequence, we can see that it did not significantly outperform any of those models. We also did pairwise comparison of the individual sequences, and again, no sequence resulted in a better performance. There were 4 qualitative semantic features with significant predictive power in terms of tumor entity. Tumor localization deep to fascia, or intramuscular location, were more frequently seen in benign myxomas. Any involvement of the neurovascular bundle, either abutment or encasement, and transcompartmental extension were seen more commonly in myxoid sarcomas. However, when we added these semantic features to the radiomics models, here in the green column, we see that it did not result in better performance, and this was true for all tested MR sequences, with our T1 weighted subset model shown here as an example. Note the close relationship between the blue radiomics curve and the green combined radiomics and semantic model curves in the ROC plots to the left. When our radiomics models were compared to a model exclusively using semantic features, here in the red column, or shown in the red curve, all the radiomic models performed significantly better.
The current study focused on utilizing MRI radiomic models in the differentiation of myxoid sarcomas from myxomas. The results showed that radiomic models derived from T1-weighted, fluid-sensitive, and T1-weighted post-contrast sequences all demonstrated excellent discrimination between benign myxomas and the malignant myxoid sarcomas, with AUCs greater than 0.9. T1-weighted imaging demonstrated the highest AUC, while also exhibiting high sensitivity, specificity, as well as very high negative predictive value. A prior study by Martin Carreras and colleagues performed radiomic analysis in a relatively small number of cases to distinguish between myxoma and myxosarcoma. The others performed radiomic analysis based on non-enhanced T1-weighted MRI sequences and achieved an AUC of 0.885. However, a number of shortcomings of this study were noted, including a lack of training and validation test subsets. 4 out of 7 semantic features evaluated in the study had significant predictive power by univariable regression analysis in the differentiation between benign from malignant myxoid tumors. Specifically, myxomas were more likely to be intramuscular and located deep in the fascia. Myxoid sarcomas, on the other hand, were prone to abut major neurovascular bundles and demonstrate transcompartmental extension. Interestingly, perilesional fat, which is classically used to characterize myxomas, was a feature present in nearly all myxomas and myxoid sarcomas. This study was performed at a tertiary referral center, and the available pretreatment MRI examinations were heterogeneous in nature. Many examinations were performed at outside imaging centers with variable MRI system field strengths, vendors, models, operating software, pulse sequences, and sequence acquisition parameters. While such heterogeneity could be seen as a constraint in the development of optimal radiomic modeling, heterogeneous MRI datasets help to address concerns and limitations of AI models developed using highly uniform homogeneous datasets obtained from a single center, and improve validity when applied to external datasets. A drawback to studying a large population, however, is the substantial effort and time required to manually delineate and contour each tumor, which in the case of the current study required over 1,600 individual manual 3D volumetric tumor segmentations. Auto-segmentation algorithms offer the potential of high throughput processing and are likely to enhance the scalability of radiomic studies. Further opportunities in follow-up to the current study include external validation of findings with large multi-institutional datasets. In the future, a comparison of machine learning discrimination performance versus MSK radiology experts might offer additional insights and further support the translation of these models for use in routine clinical practice.
The take-home points from this study are that MRI Radiomics, using any individual sequence of T1-weighted, fluid-sensitive, or T1-weighted post-contrast, is highly accurate in differentiating myxomas from myxoid sarcomas. We also demonstrate that model performance did not improve if we expanded to include qualitative semantic features or we used multiparametric imaging data. Thank you for your attention.